memo, if you haven't read them, and the new improved memo of league support, I urge you to do so. They are on the New York State website. Next slide. Most important, our position calls for universal health care. Universal health care, available statewide for every New Yorker. Healthcare that is equitable, the same high quality for the governor and you as for the woman who works at the local daycare, the man who cuts your lawn, and those who do backbreaking work on farms. It needs to be comprehensive. All essential healthcare services, including education and prevention, and reimbursing providers fairly and letting them consistently practice standard of care, regardless of a patient's race, residence, or income, or the relative difficulty or profitability of their health need. And it needs to be affordable, separated from employment status, and publicly funded so that the insurance risk is spread across old and young, healthy and unhealthy. Next, a bit of context. I'd like to open with 3 assertions, perhaps a bit contentious, to help guide discussion of healthcare policy. First, racial disparities are not genetic. As the AMA announced last summer, data demonstrates that our healthcare system is racist. For example, the states in dark blue did not extend Medicaid after the ACA legislated the federal budget to pay for extending benefits. That means that more than half of Black Americans who could have been eligible for Medicaid don't receive it. And for this reason and other reasons, Black Americans are 50% more likely to be uninsured, dramatically reducing their access to all but emergency health care and limiting even that. Finally, healthcare facilities that serve Black and Latinx populations get far less funding than those serving white majority patients, all over the country and in New York State. Second, today's for-profit funding of healthcare is unsustainable. It doesn't just fail to control costs, it's the reason costs are uncontrollable. It increases healthcare disparities by rationing healthcare by income and zip code rather than by need. It causes impoverishments, once only among the poor, but increasingly it's helping diminish our middle class as the cost of insurance continues to increase at twice the rate of wages, and cost sharing, the part we all pay out of pocket, keeps increasing even faster. Finally, and this is something you should ask Dr. El-Sayed, our current system is burning out physicians, teaching them to accept disparities in treatment as normal and corrupting medical education. So, our current system is not just unsustainable, it's dangerous to our economy, which is now swallowing $1 out of every $5 and rapidly heading to $1 out of every $4. It's dangerous to our public health. Consider COVID, where 5 times as many minority Americans have sickened and 2 to 3 times as many have died, and where cost cutting prior to COVID left us with too few beds and too few supplies, putting all of New York into crisis last March. It's dangerous to our democracy, where those in ill health who cannot pay for healthcare are suffering deaths of despair, social isolation, and radicalizing political polarization. And it's endangering the quality of healthcare for all of us. Third, public health experts often talk about the social determinants of health, how the quality of our health is due 20% to the healthcare we get and 80% to other factors in how we live. Dr. El-Sayed will tell you that sickness impoverishes us and that poverty sickens us. Our current healthcare system is a self-reinforcing vicious circle destroying the lives of increasing numbers of Americans. Ask him how universal healthcare can be an anti-poverty initiative, lifting 20% of Americans out of poverty. As we go through the next 20 minutes, think about what questions you want to ask Dr. El-Sayed and put them in the chat, please. Next. Now let's look at some disparities of outcome by race, residence, gender, and income. Next. See the dotted line and the average lifespan for G7 countries, meaning France, Canada, Germany, Italy, Japan, and the UK. It's almost 82 years, while white Americans live for 78 and a half years, 3.5 years fewer. But note that Black Americans, it's 7 years fewer. And for Native Americans, it's 9 years. And COVID worsened these disparities. White Americans have lost 9 months, while Latinx have lost 4 years, and Black Americans have lost an additional 3 years. Why is this if it's not genetic? Partly, it's that lack of access to healthcare means our marginalized populations live with seriously untreated conditions before COVID. These are the 5 leading causes of death. Many of you may have firsthand experience with how well these can be managed. But for every one of these, more Black Americans suffer and die earlier than white Americans. For example, 15 months earlier for heart disease. And all of these conditions are preventable when caught early, treatable when the resources are there, and manageable when there's adequate support. Note that COVID targets respiratory and vascular systems, making these existing conditions lethal. Now let's look at maternal deaths. In America, 3 times as many Black moms die per 100,000 as white moms, and Native American moms die at double that rate. Relative to OECD countries, Canada does not have great metrics. 90% of its population lives close to the US border. The highest birth rates are among the 10% of Canadians spread over a landmass larger than the entire continental US. Lack of access kills. But American moms die at twice the rate of Canadian moms. When the AMA announced last summer that racism is endemic in American healthcare, what did they mean? Well, we can start with interpersonal racism, patterns in how healthcare workers treat minority patients. But let's be clear that bias is intersectional. Take the headlines around Serena Williams in 2018. Despite a history of potentially lethal blood clots, doctors and nurses ignored her pleas to be tested. They didn't trust her to know her own medical history or her own body, and it was almost too late. Her wealth and her celebrity didn't help her. Being Black and female can be dangerous to your health. Was it because she was a tennis player and not a physician? Nope. Earlier this year, Dr. Susan Moore, a Black physician hospitalized with COVID, repeatedly described unbearable pain to her physicians, and they assumed she had a substance abuse problem, not serious COVID, because Blacks don't actually feel pain. Well, more about this later. While they were writing discharge papers, she recorded a phone video testimony of these conversations, her symptoms, and her fears about discharge. Lack of respect for patients can kill them, even when they are physicians. But there's also widespread diagnostic bias caused by medical training that perpetuates unsubstantiated myths. Here are a few. A medical manual written in 1787 decided that Black people are insensible to pain. And in 2016, half of surveyed medical students believed race affects pain perception. Still. In the 1840s, the first spirometers, those are the plastic doohickeys that you breathe into after an operation, measured less lung capacity among enslaved Americans. Modern spirometers have a setting for race that adjusts 15 to 20% less lung functioning as normal, distorting diagnoses for asthma, COPD, and COVID. It also delays and deprioritizes lung transplants for Black patients. 3 years ago, a medical student researched this. Her findings caused shockwaves across the medical world, but the adjustments still continue. Many common blood tests also make racial adjustments. For example, the EGHR normalizes 20% worse results for kidney failure among Black patients as normal. Does this explain why so many Black patients learn they have end-stage kidney disease as their first diagnosis? In 2020, the American Society of Nephrology and the National Kidney Foundation formed a task force to study the race-based adjustment. Their initial conclusion was that race modifiers should not be included in equations used to estimate kidney function. But there has been no call for implementation yet. Algorithms, or artificial intelligence, promises objective assessment of prognoses and treatments. One commonly used algorithm assesses complex cases to recommend whether additional critical care will benefit patient outcome. It was based, however, on flawed data. Removing racial bias would increase critical care from 18% of Black patients to half of Black patients. Consider also the algorithm used for the National Football League settlements for retired football players with concussions. The algorithm used to measure cognitive injury assumes that normal Black athletes is a 20% lower score on cognitive functioning than normal for white athletes, requiring 20% greater impairment to be eligible for settlement funding. Finally, there are issues of structural bias, including racism. Let's look at some of them by looking at healthcare disparities among rural residents. Rural residents die on average, next slide, 3 years sooner. 3 years sooner than residents in cities and suburbs. So what do they die of? Interestingly, the 5 leading causes of death are the same for urban and rural Americans. But while recent decades have seen death rates per 100,000 drop precipitously in urban and suburban areas, not so for rural residents. They live sicker and die sooner. Note that cancer and lower respiratory diseases kill at quadruple and triple the rate of suburban and urban residents. I hope you're shocked. Rural moms are 60% more likely to die than moms who live in more densely populated areas. And similar tragic disparities are true for infants. 1 out of 3 rural seniors has no teeth, 50% more than those who live elsewhere. Research shows that the risk of death triples for people with no teeth over those with 20 or more, and it doubles for those who have lost some teeth, but not all. Rural areas have half as many dentists spread across greater distances. New York State averages 1 dentist per county or less for half our counties. Cost and distance mean that 70% of rural residents with dental needs have not seen a dentist for over a year. In fact, rural residents are 20% less likely to have health insurance than other New Yorkers, partially because rural jobs are among the least likely to offer benefits. Sorry about that. And partially because, sorry, I'm gonna let that run. Benefits. Agriculture jobs, meat processing, and dairy jobs don't give benefits. And because job-based health insurance is more typically offered to those with higher paying jobs, 85% of those in a family of 4 earning $100,000 a year will likely be offered health insurance with their job, while fewer than a quarter of those earning $26,000 will. So on average, rural residents live sicker, die sooner, and don't have health insurance. What other structural disadvantages can we discover? Well, across the country, 166 rural hospitals have closed in the past 15 years, with over 700 more currently in dire financial straits. 47 hospitals filed for bankruptcy just in 2020. In New York State, 41 hospitals have closed general inpatient services in the past 20 years. 16 eliminated all medical services. In the year 2000, New York had 40% more hospital beds than they have now. This affects New York City, but it really affects rural New York State. Today, the US has 2.8 hospital beds per 1,000 people. France has double that, and South Korea has more than 4 times as many. Let's take a quick look at hospitals availability in Manhattan, the most densely populated county in the US and one of the most densely populated areas in the world. The area just to the right of the green rectangle, which is Central Park, is the Upper West East Side, a few square miles of concentrated wealth and a dozen prestigious hospitals. All of them thriving, despite 17 New York City hospitals having closed in the past decade. Doctors' offices are everywhere in this area. It's a case study for how today's for-profit funding of healthcare concentrates resources to maximize profitable customers. You don't find profitable customers outside of cities. Compare the shortage of primary care doctors in most of the 3,000 US counties. Those are the dark blue blocks. In the New York State's inset, you see a double handful of counties where the whole county has a shortage, and most of the others are showing only part of the county in shortage. I apologize for the blurry images. Images provided by the March of Dimes are really fascinating, but they have too few pixels. Maternity care across the country is even worse. But here in New York State, the 17 dark blue areas on the left-hand image have no hospitals within the county, and the 20 paler blue have 1 hospital. That's more than half of New York State counties. The middle image, green and white, shows where OB/GYN doctors and nurse midwives are scarce. And the image on the right shows the 2 counties classified by the March of Dimes as maternity care deserts. No hospital, no birthing center, no OB/GYN, no midwives. And 8 are near deserts. Do we wonder why pregnancy is dangerous for rural women and their babies? So living in a rural zip code is risky. Urban zip codes are a bit more complex. To keep families in their homes and prevent foreclosures during the 1930s, the New Deal began guaranteeing home loans. To help banks manage risk, the Federal Housing Administration drew maps of cities across the US. Neighborhoods with Black people and poor people were shaded red, as in the map on the left, so that banks could refuse home loans to residents who lived inside these red-lined areas, regardless of their individual circumstance. In the southwest corner of the map on the left, see red-lined Harlem with the South Bronx just north of it, and the red areas in the north of that is the East Bronx. Compare these red-lined areas with where we saw the greatest per capita COVID deaths. Note Harlem, the South Bronx, and the East Bronx have lost 0.5% to 1% of their residents. 1% of their residents. This is the equivalent of having 3.3 million Americans die. Now look at life expectancy by zip code for this same area. Based on 2015 data, note the area inside the red circle. The Upper East Side, with all the hospitals, has a life expectancy of 85 years, higher than Japan's, which is the highest in the world. And above 96th Street, that's that sharp barrier between those 2 areas, is Harlem, delineated by redlining almost a century ago. Longevity is 11 years less. It's like Mexico or Sri Lanka, 1 bus stop away, although gentrification is blurring that a bit. This is why CDC advisors in the American College of Physicians advise that vaccination should be rolled out by zip code, not age. And like the closings of hospitals and clinics, which have disproportionately harmed both the Bronx and rural New York, like the shortages of primary and maternity care physicians, this is structural racism. the direct result of public policy. So what might we expect from public policy that overcomes this structural bias? Just to repeat, the same diseases that kill the typical American kill marginalized Americans, but at shockingly higher rates. Modern medicine, the kind enjoyed by residents of Fifth Avenue and Park Avenue, can manage and control these conditions when patients have access to healthcare, when healthcare is affordable because it's covered by insurance, and when providers are not impossibly far away. This 86%, this is so wrong. These are people. Our current privately funded healthcare system disrespects human life, unlike our publicly funded healthcare systems. For example, Black soldiers and veterans thrive with single-payer universal healthcare, totally funded by taxes. To read this chart, look at the red line showing parity with whites. The green columns below the line show better outcomes for Blacks. Black soldiers and veterans live longer than white soldiers and veterans. They have fewer cardiac events and fewer strokes. Further, kidney disease, which affects 4 times as many Black Americans as white Americans, because Black Americans are 13% of the population, but account for 35% of those with kidney failure. Perhaps, as we've seen, because routinely race adjusting the EGHR and other tests gives false normals. In the VA, that disparity is turned around. In our military, the 7 to 9 years of racial longevity gap closes. So how do Americans fare relative to residents of other wealthy countries? This chart shows that life expectancy on the vertical axis, each country has a dot, and the higher the dot, the longer the average life. Japan, Italy, France, Spain, they're all at the very top, with other OECD countries just below them. And the US is in the box on the right, living 3 to 5 years less than the average of the countries in the upper box. But the horizontal axis is how much each country spends. This chart is a few years old, but the ratio of peer countries spending half of what we do remains. In 2019, the US spent above $11,000 per capita, with peers spending half that. More frustrating, about 7,000 of our total spending comes from our taxes. So we spend more in taxes on healthcare than peers with universal healthcare do. And then we add another 4,000 from our individual pockets to get worse results with many of us uncovered. Which brings me to my very favorite slide. American life expectancy at birth, we come in 17th out of 17 peer countries. And we pretty much stay that way for 6 decades. And then it begins bouncing around a little bit in our 60s with a spike in scary diagnoses at age 65 for cancer and other diseases, when seniors who waited for their Medicare card finally began getting regular checkups and screenings. And then, in the next 5 years, Americans suddenly start living as long as those in countries who live the longest. What happens in America beginning at age 65? Is there something special in the water? Is the genetically weaker seniors, they all die off? Or does accessible, much more affordable universal healthcare improve lives? So now let's introduce Dr. El-Sayed. Physician, epidemiologist, public health expert, and progressive activist. He's a senior fellow at the Harvard Graduate School of Public Health, and he's scholar in residence at Wayne State University and American University, where he teaches at this intersection between public health, public policy, and politics. His books include Medicare for All, A Citizen's Guide with Dr. Michael Johnson, A No-Nonsense Guide to Policy. I thoroughly recommend it. It's a fascinating read. And Healing Politics, A Doctor's Journey into the Heart of a Political Epidemic, which touches the heart. He earned his medical degree from Columbia and his doctorate in public health from Oxford, where he was a Rhodes Scholar. He served as one of the 8 members of Biden's Unity Task Force on Healthcare, and he ran for governor of Michigan in 2018. From 2015 to 2017, he served as health commissioner for the city of Detroit, where he was appointed to rebuild the health department after it was privatized during municipal bankruptcy. As the youngest health official in a major U.S. city, he focused the Detroit Health Department on public health innovation and environmental justice, successfully leading one of the fastest municipal turnarounds in American history. It's very exciting to have Dr. El-Sayed join us to discuss healthcare through a DEI lens. And if we can stop screen sharing,